Hey, this is Christy Cornett. I'll be doing my presentation today on cholecystitis and cholelithiasis, and this is for Nursing 2. Cholecystitis and cholelithiasis. Cholecystitis is inflammation of the gallbladder. This slide shows a picture of cholecystitis. It shows the common bile duct, the cystic duct, that shows a couple of gallstones through that duct, and then it does show some larger gallstones in the gallbladder. Cholelithiasis is the presence of gallstones inside the gallbladder. In this slide, you can see a picture of the gallbladder with stones inside, and you can see in relation to the scalpel how large it is. Cholecystitis can be caused by different things. One is just an obstruction, 2 gallstones, and 3 tumors. Most of the cases of cholecystitis are caused by gallstones, about 90% actually. When it's caused by an obstruction of gallstones or a tumor, it kind of keeps the bile trapped inside the gallbladder, and the bile irritates the gallbladder wall. It causes like an inflammatory response, and the gallbladder becomes swollen and irritated, causing cholecystitis. It is more common in women than in men, more common in Native Americans, white Americans, and African Americans. It's more common in overweight people, pregnant women, people with diabetes, and women who use birth control pills. There are several things that play a role in the formation of stones: chronic stress, low-fat diets, leaky gut syndrome, blood sugar imbalances, and obesity are all contributing factors to the formation of stones. The exact cause is not known, but we know that those are different things that do contribute to the formation. The stones usually occur in multiples, but you can also just have one. It is not uncommon to see just one single stone. Clinical manifestations of cholecystitis are usually a sudden onset of indigestion or heartburn feeling, feeling nauseous, and vomiting. You also may have like a colicky, sharp abdominal pain in the right upper quadrant, and it can also travel to the right shoulder and scapula, which is also kind of like when you have a cardiac issue, and it kind of presents in that same way. So a lot of cholecystitis patients do think that they might be having some kind of heart issues. Okay, and this one is about cholelithiasis, and in cholelithiasis, when the gallstones start moving through the biliary ducts, the patient often complains of their pain just intensifying, and maybe they've had the dull, achy pain with the cholecystitis, and when those gallstones start moving, then their pain intensifies, and they can definitely tell something's different. Subjective nursing assessments for cholecystitis, cholelithiasis are course, nausea and vomiting, anorexia. The patient might present with flatulence, complaints of an increased heart and respiratory rates. They may seem diaphoretic, and they will probably also be complaining of indigestion after eating foods high in fat. They'll also have like it's like a pain in their right upper quadrant, and it may radiate to the back or right scapular area. The objective nursing assessments for this disease, you'll probably see a low-grade fever. They will have increased pulse and respirations, nausea and vomiting. They'll have an elevated white count. They'll probably have some jaundice, steatorrhea, which is just stools that you can actually see the fat content in. They might have some tea-colored urine or clay-colored stools. Diagnostic tests include fecal studies. They'll do like a bilirubin blood test, a gallbladder ultrasound, a HIDA scan, or an oral cholecystogram. They may also do an operative cholangiogram, which is just like they will inject radiopaque dye into the common bile duct, and they usually do that at the time of surgery. Okay, medical management for the treatment of mild cholelithiasis would be more on the conservative side. They may have you go on bed rest, avoid spicy foods. They may insert an NG tube and have it connected to low suction. They may place you on an NPO status and give you IV fluids just in order to rehydrate you. They may give you some antispasmodic and analgesic drugs to decrease the pain if you're in quite a bit of pain. And they may also give you some antibiotics, either to treat an existing infection. They may give you prophylactic antibiotics, or after a perforation if that should occur. Now, they do not usually give morphine as pain medication because it increases the tone of the sphincter of OD. And dicyclomine is used to decrease the spasms of the sphincter of OD. And that controls the flow of pancreatic juices and bile into the duodenum. Okay, for treatment of mild to moderate cholelithiasis, they may do a lithotripsy. In the lithotripsy, it discharges a series of shock waves, and that can either be through water or a cushion. And when those shock waves hit, it breaks the stone into fragments so that can be passed through the biliary system. Okay, a cholecystectomy is the actual removal of your gallbladder, and that can be done two different ways. One is a lap chole, which is just short for laparoscopic cholecystectomy, and that is actually the most common kind of removal. The other is an open abdominal cholecystectomy, and it's not used as much, but it is often used for removal. In the lap chole, you have less pain. It's not as expensive as the open abdominal cholecystectomy. You don't have as big of a scar. It's less invasive, so that means there's less chance of infection or respiratory problems during the surgery. This actually accounts for about 80% of the cases in gallbladder removal. Now, the open abdominal cholecystectomy is pretty much used when you can't do the laparoscopic cholecystectomy or it is unsuccessful. It is, however, performed like when you have another abdominal surgery, if you're already open, like if you're having a colon resection or something like that, the surgeon may feel it necessary to just go ahead and take your gallbladder out while he's already in there. Okay, some preoperative nursing interventions that we need to do would be to just get to know your patient, assess their pain level, assess what their skin, eyes, and mucous membranes look like, if there's any presence of jaundice there. You'd also look at their urine and stool to see if you can see any bilirubin spilling over in that. You would give them some antiemetics if they're nauseated, and if that becomes a problem, this is very important that you measure their I's and O's carefully and keep very, very close track of that. Would also have them turn, cough, and deep breathe, use their incentive spirometer, and also teach the patient to splint the abdomen in doing that. It's important to do all of this before the procedure, because after the surgery they're not going to be as it's not going to be as easy to teach them to do these things. You'll probably also need to explain to the patient what they should expect after the surgery. Tell them they're going to be connected to the IV tubes, the catheter that they'll have. The medications that they'll probably receive would be like pain medicines, vitamin K, antibiotics, and any medicines for nausea that they might need. Okay, post-operative nursing interventions would be to monitor their vital signs, have them rest in a semi-Fowler's position to help with the drainage, the flow of the drainage, monitor the drains that they may have for patency to make sure everything's flowing appropriately, and if the drainage that you see in the drains, if it's alarming, like if it's bright red, or if you can see that there's bile in it, or if there's just a whole lot of it and it doesn't seem normal to you, then you should always notify the surgeon immediately. As with any other surgery, you need to encourage deep breathing exercises, cough, turn, deep breathe, and to use their incentive spirometer. We would have them dangle before ambulation, and we're probably not going to have them ambulate until the first post-operative day. We would check their neurostatus several times, maintain fluid balance with IV therapy, and just keep a close watch on their I's and O's. You may have T-tube care, and we need to keep a close watch on their dressings to make sure there's no exudate or hemorrhage on that. Some other post-operative nursing interventions would be to check for bowel sounds every 8 hours, make sure the patient is passing gas. They would probably be on a clear diet for the first 24 hours, and then we would probably increase them as they could tolerate after that. We'd also need to make sure to document and let the surgeon know if they had any major complications of jaundice, hemorrhage, if their temperature spiked, or if they had any signs and symptoms of pancreatitis, because that would be alarming and would need to be, the surgeon would need to be notified about those things. Okay, some patient teaching that we would need to share with the patient would be just how to identify the signs and symptoms of things that they need to be worried about. If they suddenly become jaundiced, if they have some excessive bleeding, If they see that they have some leakage of bile, their temperature is elevated, or if they have a sudden increase in pain and they can't get it, if they can't tolerate it or can't get it under control with some analgesics, if they have dietary intolerance, that's probably something that they would at least need to call and report. If they had a T-tube, we would need to teach them about that, and we would need to make sure that they knew how to take care of it, and we would observe them showing us or demonstrating to us that they did know how to do that. The dietary teaching for both conservative treatment and surgical treatment would be on conservative, you would just avoid fatty foods, fried foods, spicy foods, no whole milk, chocolate, peanut butter, anything like that, any gravies or butters, no nuts. But if you had surgical treatment of your cholelithiasis, then you should be able to start trying small amounts of the foods that used to be bothersome to you before the surgery, and you can teach them that they can normally go back to a normal diet without any difficulty, but it would just need to be probably at a gradual pace. There are also several things that we need to assess on the patient just to try to prevent complications, make sure they're not having any signs and symptoms of biliary cirrhosis, fistula, pancreatitis, rupture of the gallbladder, or maybe a stone occluding the common bile duct. The prognosis for cholecystitis, cholelithiasis, would be, as long as it's taken care of and you get it under control with prompt treatment, the prognosis should be excellent and shouldn't have any problems.